Second of the New Year's Grandrounds, and I'm really excited to hear the talk of my colleague, Dr. George Phillips. George graduated, I guess his undergraduate degree was at Penn State in the Paterno era. Yes. I guess not a was it, at the time it seemed like a good idea. And then went to the University of Rochester School of Medicine and Dentistry, where he graduated with an MD degree. Then came south and did his residency at UAB, and then a fellowship at Duke University in gastroenterology. Did some time as a faculty member at the University of Rochester. How long were you there?
2 years.
2 years on faculty, and then decided that he wanted to go back and learn some more stuff about scoping, and did a year's fellowship in interventional endoscopy at Emory University, and then joined us after that was completed, and has been with us about 3 years now. Almost two and 3 years. He's an expert in all things endoscopic, biliary, pancreatic, and also has some novel techniques for taking care of some esophageal motor disorders and some things like achalasia. So I'm really excited to hear his talk, and without further ado, I'd like to introduce Dr. George Phillips.
Thanks for the introduction, Lou. So my talk is going to be on esophageal motility disorders, hard pills to swallow. I think this is a challenging set of disorders, not only to recognize but to diagnose. And so I think it's both troublesome for the patient as well as the clinician. I have no disclosures. I wanted to frame my talk with a case presentation that presented to me about a year and a half ago. It was a 45-year-old overweight male that presented to my office with a 1-year history of intermittent dysphagia to solids and liquids. He states that food gets stuck in his chest, accompanied by substernal burning, discomfort, and weight loss. On further history, he does support some intermittent spasms of chest pain without any associated angina, chronic cough, or palpitations. The chest pain is associated with eating. Throughout the course of the talk, I would like you to focus on these questions, and we'll come back to them at the end. The first would be, what is your leading differential diagnosis in this case? Based on that, what would be your diagnostic workup? And finally, what management options are available, assuming the diagnosis is made? So the objectives of this talk are to A, review the anatomy of the esophagus, review the phases and control of esophageal function, review diagnostic testing, and provide an overview of prominent motility disorders. For the duration of this talk, I don't want to get too specific, but we'll kind of give you a broad overview. And I wanted to focus on one particular better understood esophageal motility disorder, and that is achalasia, and talk about some updates on current management. So let's begin with the esophageal anatomy. The esophageal anatomy is a muscular tube approximately 18 to 24 centimeters. When we're doing endoscopy, we typically measure from the incisors, and we usually quote a length of 40 to 45 centimeters. Basically, it starts at the cricoid cartilage, and it goes down to the gastric cardia. It's basically has three general areas. The upper esophageal sphincter or cricopharyngeus muscle, the esophageal body, and that can be subdivided into cervical and thoracic, as well as the lower esophageal sphincter. And there are three areas of natural constriction in the esophagus. As we mentioned, the cricopharyngeus, which is a muscle, it does sit behind the aortic arch, and so there's a segment there that does have some structural slow flow. And then there's the lower esophageal sphincter, and that's thickening of the circular muscles. It is fixed in two places, as I mentioned before, in the upper and the lower portion. The lower portion is particularly important. It's the phrenoesophageal ligament to the esophagus. And the reason why this is critical is because it helps to fix the esophagus at the G junction, which is part of the mechanism for preventing GERD. And when this gets disrupted, people have more symptoms of reflux disease. Now, the structure of the esophagus is also important to know. So, especially if you're doing endoscopic ultrasound or endoscopy, going back and understanding the tissue layers and the tissue planes becomes important, and I will get back to this later in the talk as well. But essentially, there's three main layers to think about: the mucosa, the innermost layer, and the submucosa. And above that is generally what we call the muscularis propria or externa, which is divided into two muscular layers, the inner circular muscles and the outer longitudinal muscles. And when we talk about treatment for achalasia, knowing this anatomy becomes important. Now, in terms of the phases of swallowing, so as you will recall, so let me just go back to the esophagus. So that the top third of the esophagus is innervated by skeletal muscle. The bottom 2/3 is smooth muscle. And so the initial phase, the oropharyngeal phase, where you transfer the bolus from the back of the oropharynx to the proximal esophagus, is actually voluntary. And then after it gets past what they call the transition zone, where it goes to the smooth muscle, it becomes an involuntary process. And that is coordinated by the vagus nerve, and you get EUS relaxation, peristalsis, which is coordinated, and then lower esophageal relaxation. Now, between swallows, the UES prevents air entering the esophagus and prevents esophagopharyngeal reflux, and then the LES prevents reflux. And then there's a capacity for belching and vomiting and decompression as needed. Now, to look at this in more of in figure form, here's basically a diagram, and what you can see here is at the top is the pharynx, the upper esophageal sphincter, the esophageal body, and there's a thoracic version and a thoracic version, and then there's a lower esophageal sphincter and a stomach. Now here, what they're measuring is the bolus. Okay, so this is, if you can imagine a food bolus. So a food bolus travels down the esophageal body, and you can see the UES relaxes initially when bolus hits the pharynx and it's transferred into the proximal esophagus, and then there's a bolus pressure. But throughout, and the peristalsis kind of has a coordinated pressure and pushes the bolus down. Throughout this period, which is roughly about 10 seconds, the lower esophageal sphincter is completely relaxed and open. And this will become important downstream. But what it shows is that in general, esophageal peristalsis is a very coordinated maneuver. And whenever this gets disrupted, we get motility disorders. This is just a broad categorization based on what I just talked about motility disorders. You have the upper esophageal disorders, which involve the cricopharyngeus. There's a few primary cricopharyngeal disorders, but predominantly, especially we being a stroke center, typically have neuromuscular manifestations of dysmotility in this area. And then you have primary esophageal body disorders. The best understood is achalasia, which I'll come back to later in the talk. Diffuse esophageal spasms, nutcracker esophagus, which we may have all recalled from medical school in later years, and nonspecific esophageal dysmotility. And things can also involve the lower esophageal sphincter, achalasia, and hypertensive LES. You can also classify motility disorders according to primary disorders, that is, primary disorders that involve the esophagus in and of itself, or manifestations of other disorders like diabetes, scleroderma, Parkinson's disease, or as mentioned before, stroke. Now, as a clinician, what tools do you have? Being a medical center, I will tell you, and one that should be emphasized over and over again, is a thorough history and physical exam. We have a lot of tools, and I think doing a thorough history really sets you up and sets your pretest probability for further diagnostic testing. We do use a lot of modified barium swallow studies here, especially being a stroke center, to evaluate the predominantly upper esophageal sphincter and cricopharyngeus. And there's a barium esophagram, endoscopy, and manometry, which I'll touch upon a little bit more, as this is, I think, an underutilized resource within our facilities. So the first thing is clinical assessment of dysphagia. So this is based on an algorithm back from 1987, but I think it's something I routinely go to whenever I'm in clinic. The first thing is just to get a general sense of what the patient feels. Do they have a lot of nasopharyngeal regurgitation, or do they feel like stuff gets stuck in their chest when midway through a meal? Those are kind of the initial questions I ask. And whenever they talk about stuff in the chest, you start to wonder about esophageal dysphagia. And then the next thing in the algorithm is really to ask, is it solids or solid foods and liquids? And whenever they talk about foods and liquids, you really start to wonder about neuromuscular disorders. And then you kind of talk about intermittent, progressive, and you can further stratify what your pretest probability is. And then the testing kind of goes along with that. Here, if you notice, the big difference down this cascade, if you really strongly suspect a neuromuscular disorder, you start to think about manometry. The other thing I want to point out in this is chest pain here. We have the Heart and Lung Institute here, and there's a lot of non-cardiac chest pain. And I think manometry, which I'll get back to, is an important resource here that we can offer these patients, because oftentimes this is a challenging diagnosis to make. Now, just briefly, I'm sure a lot of this is review for most of you, but basically, there's a lot of bedside radiographic evaluation, being a stroke center. But basically, under video fluoroscopic guidance here in this image, you can basically watch as modified barium is swallowed, and you can test the pharyngeal transfer mechanism. The next is a standard barium esophagram. And it basically this is just a depiction of what we normally would see in the esophagus. Of note, in clinical practice, in your clinics, if you were worried about a stricture, which are sometimes very, very subtle and hard to find, you can ask them to add a 13 millimeter barium tablet, and that would tell you if there are subtle strictures or areas where boluses can get caught. Now, endoscopy, I am an endoscopist by trade, and I will say that endoscopy is part of all the guidelines regarding achalasia and neuromuscular disorders, but there are pros and cons to it. The pros, it's direct visualization of mucosa, and it's an opportunity to biopsy abnormalities. In this case, this would be a case of pseudoachalasia, where there's basically an esophageal mass that's sitting there. There's cons, though. A lot of what we do, if you talk to the GI staff, we call it we've nicknamed it the GI ICU, because we're basically sharing an airway, and a lot of the patients we deal with have a lot of cardiorespiratory comorbidities, and so that can be a frequent cause of complications. And it's an expense with potentially little benefit, especially if you're strongly suspected neuromuscular disorder. And then it brings me to, I think, probably what would be standard of care at this point, if it's available in your facility, which it is here, and that is esophageal manometry. And now it's become high-resolution esophageal manometry. Before they used to have a smaller catheter, but now they have what they call a high-resolution catheter. There's 36 solid-state pressure sensors in 1 centimeter intervals across the entire catheter, and it basically measures esophageal motility from the UES down through the LES, and is the most sensitive instrument we have to evaluate esophageal motility. And so this is just a representation, but on the left here, you see that this used to be the traditional manometric evaluation before we had high-resolution manometry, and here is kind of the more the better output with the high resolution manometry. This is just for representation, but here you can see again, like I showed you before, it's a very, very discrete process. When you swallow, you basically have an increase in bolus pressures that have a linear output. And during this entire time that the esophagus is using peristalsis, you have LES relaxation, which becomes critical down the road. And this is a depiction of what you would get with a high-resolution esophageal manometry catheter. I'll kind of work through this a little bit. So this is from gut. So it's from a British journal. So everything that's E is actually they spell esophagus with an O. So it's actually upper esophageal sphincter, and this is depicting the swallow. And this is the proximal esophagus, the mid, and the distal esophagus. And this is the intrabolus pressure, IBP, and this is the rise in the intrabolus pressure, and that's depicted by green. It's typically around 30 millimeters of mercury. And then you have the lower esophageal sphincter here. And you can see that this area here is a natural zone. It's physiologic. It's where the skeletal muscle is transitioning to the smooth muscle. And it typically is an area where you get lower bolus pressures. And this is the gastric lumen. And so here is a normal swallow, where someone is swallowed, and you get a bolus pressure here and a rise as it's going down through the esophagus. Now, just a quick primer, because a lot of this is foreign to people, and it's actually quite a challenging science to follow. But basically, there's three parameters that we look for. So we look for the integrated relaxation pressure, or IRP, and that basically defines the mean esophagogastric junction pressure for 4 seconds. It's normally less than 15 millimeters of mercury. The distal latency is the interval between the upper esophageal sphincter relaxation and contractile deceleration, and that's less than 4.5 seconds. And the distal contractile integral is basically just telling you how much power the esophagus is pushing with or exerting. So if I was to show you kind of actually what it was, here, let me just go back. So what they're talking about here is the IRP relaxation is here, this area here. If it's not relaxing, then there's a problem. And the interval is basically the length of time here that they're talking about. So from the high-resolution manometry catheter, basically they came up with a simplified way, and that's the Chicago classification. And so basically abnormal EG junction relaxation, which is defined by the IRP, is basically used to break down motility disorders. And then you have absent peristalsis and then intact peristalsis. And then you have other definitions here, which I'll briefly go over. But essentially, the whole framework is really to define achalasia versus non-achalasia, because essentially achalasia is the best defined esophageal motility disorder that we have. So just a brief overview of the esophageal motility disorders. Like I said, the presentation, typically difficulty swallowing, chronic cough, recurrent aspiration, inability to swallow saliva, nasopharyngeal regurgitation. Commonly neuromuscular disorders, cricopharyngeal dysfunction. And then the testing is usually, like I mentioned, modified barium swallow and esophageal manometry. Now, the motility disorders of the body and lower esophageal sphincter. The presentation is a little bit more indiscreet, if you will. As mentioned before, it's intermittent. The idea is usually it occurs with solids and liquids. And I think the other thing to point out is usually the other scenario that we will see it in GI clinic would be refractory reflux disease. So if we do the full workup, they get a PPI trial, it's ineffective, they continue to have symptoms of reflux, you start to worry about a motility disorder. It also is important, the testing is also important because if you're ever considering surgical reflux therapy, manometric evaluation is crucial. So those disorders are spastic disorders, diffuse esophageal spasm, nutcracker esophagus, jackhammer esophagus. And there's lower esophageal disorders, hypertensive LES, and achalasia. And then you have hypomotility disorders, usually which are secondary, most often which is associated with scleroderma. The testing for this group, which you can order even before ever referring them, would be a barium esophagram with or without a tablet, endoscopy and esophageal manometry. So just some of the other interesting spastic disorders of the esophagus in the body would be diffuse esophageal spasm. It's frequent non-peristaltic contractions, and basically there's simultaneous contractions in 2 or more recording leads. Typically occurs with greater than 30% of wet swallows. In a manometric test, what they typically do is it'll be 10 swallows that they do in a session. So it's usually about 3 of those swallows you get simultaneous contractions. And kind of the more newer criteria, a latency of less than 4.5 centimeters. So in other words, this time period between of relaxation is shortened to less than 4.5 seconds. Nutcracker esophagus, which we all have heard about, it's probably been a board question before, but it's high pressure peristaltic contractions. Usually the average pressure is greater than 180 millimeters of mercury in old criteria, and usually have long duration contractions as seen here. You can see that there's a long, here's the swallow, and there's a long contraction that's extremely high. It's in the, it's in this range here. And the neuromanometric classification is that power that the esophagus has to squeeze is over 5,000 units. Other hypermotility disorders, hypertensive LES, high LES pressure. Normal peristalsis is usually classifies it, and it usually overlaps with other hypermotility disorders. It's sort of a basket, if you will, for other kind of unusual hypermotility disorders. And there's nonspecific esophageal dysmotility as well. For hypomotility disorders, I think there's a few primary or idiopathic related ones. Typically, it's age-related. I usually term them presbyesophagus, and they have low contraction pressures. Sometimes they get diffuse esophageal dilatation as well associated with it. And they have incomplete peristalsis in 30% or more of wet swallows. Secondary causes are scleroderma in greater than 75% of patients, and it's progressive, usually associated with incompetent lower esophageal sphincter with reflux. Crest syndrome, polymyositis associated with it, diabetes, and then there's a lot of miscellaneous reasons, hypothyroidism, alcoholism, amyloidosis, or infiltrative lesions would cause it as well. And this is just representation of what you would see as opposed to hypermotility disorders. Here you see this would be a normal swallow. Here you see up to the skeletal muscle. And then it's completely blue. There's absolutely no bolus pressures that are generated within the esophagus. And if you notice down here, on the left here, you see that there's some residual lower esophageal sphincter pressure. There's absolutely none here, which is consistent with hypomotility disorders and incompetent LES. So I think everyone this week has heard about the eclipse, and so I think the second half of the talk is really a focus on achalasia, and I'll be introducing some newer endoscopic techniques that involve the treatment for achalasia. Before I break and get on to the second session, did anyone have any questions about a lot of the stuff I reviewed in general about hyper or hypomotility disorders? Okay, we can save some questions for the end as well. So I want to start out with achalasia and kind of a historical background. So It actually was first described more than 300 years ago, and it was referred to as cardiospasm. And it was described historically when patients were starving and unable to swallow. And at that time, the conclusion was due to lower esophageal narrowing. So it was interesting to read about this. They constructed the first dilator, which was made of whalebone and a sponge, and it was used to apparently to dilate these patients blindly, which was interesting to read about. I don't know how well it worked, but that was an interesting phenomenon. But achalasia is a rare syndrome. Part of this, I will tell you, I believe is a little bit biased. So you have to have a high pretest probability to ever diagnose it to begin with. The second thing is I think a lot of refractory GERD goes undiagnosed because of resource availability or because of diagnostic testing. And then also, we have better and better techniques to evaluate motility disorders, but that's been more recent. So I think the numbers you're seeing here are somewhat biased, but there's basically what the literature quotes is about 1 in 100,000 annual incidents and 10 in 100,000 prevalence. There's no gender or racial differences, and the peak incidence occurs between 30 to 60 years. There is an increased risk of esophageal cancer, and that is true for not only squamous cell cancer but also for adenocarcinoma. However, the predilection is for squamous cell cancer. So how is achalasia defined? As mentioned before, or I'll highlight now, it's defined by ineffective relaxation of the lower esophageal sphincter combined with loss of esophageal peristalsis. So you need both components. And it results in delayed esophageal emptying and gradual dilatation of the esophageal body, which is seen by barium esophagograms or at endoscopy. So how does it occur? It's still, in this country, it is predominantly idiopathic. We think that there's an initial insult with a viral or a toxin that causes a chronic infection and an aberrant autoimmune response. And basically you get ganglionitis or loss of neurons, and you get a decrease of the myenteric plexus ganglion cells in the esophageal body and lower esophageal sphincter. And you get a loss of inhibitory neurotransmitters in the nitrous oxide and vasoactive intestinal peptide. You get unopposed cholinergic activity, and then therefore you get incomplete relaxation of LES and aperistosis due to loss of latency. The one thing that's well described, or as I mentioned before, this is a hot topic, during medical school or during step 1, and that is achalasia in association with Chagas disease. It is, as you recall, the bug that caused it was Trypanosoma cruzi, and this just depicts kind of the highlight of it, and really shows that this is really a chronic phenomenon. So, in South America, for instance, you get an acute infection, and over time, if you develop an aberrant autoimmune response in the esophageal body or in the lower esophageal sphincter, you form chronic inflammation, and it can affect the heart with cardiomyopathy, megacolon, and megaesophagus. And this is usually decades after the initial infection. So you wouldn't expect it in a young patient in their 30s, but maybe someone from South America who's in their 70s and 80s who comes in, it may be something to at least think about. Now, the other important thing to exclude with any kind of achalasia is malignancy. There's infiltrative malignancy, so esophageal cancer, GE junction cancers, and then pancreatic, breast, lung, or hepatocellular cancers have also been described. The other thing is secondary achalasia due to surgical changes, so a fundoplication or a laparoscopic adjustable gastric banding. And this part, the fundoplication, is very important. None of your patients should really get a fundoplication without a manometric evaluation. Because if they do have achalasia and then they do a wrap on top of it, they can worsen the dysphagia. Now, the typical presentation, as I mentioned, it's a hard diagnosis to make. Excuse me. But typically, dysphagia is delayed and progressive, typically over 2 years. It can be exacerbated by emotional stress or cold fluid. It can present as atypical chest pain and refractory GERD-like symptoms and regurgitation of food. But usually dysphagia and regurgitation of food are later manifestations. I think an area that we can really capture is really these two groups. If we were to capture these referrals, I would bet we would diagnose more achalasia in time. I in clinic for additional reasons kind of assess the clinical severity. I'm pretty sure a lot of people haven't heard of the Eckert score, but it came out in 2000. It's been around for really a decade or so, but it's a way to kind of tell us how aggressive do we need to be with these patients. An analogy would be gastroparesis in our patient population. Gastroparesis has really a variable phenotype. Some people have literally no symptoms, some people have a lot of symptoms, but not everyone needs the same treatment. And the Eckert score kind of gives you a framework to define how aggressive do you need to be with treatment up front. The criteria that go into it are weight loss, dysphagia, retrosternal pain, and regurgitation. You get a 0 if there's none, and then based on the frequency of these symptoms, you get an additional score. Typically, when we're talking about endoscopic therapy or when we're talking about surgical therapy, we really like to see a score of 6 or more. And that's kind of the target. We try to get them below 6 at that point. And that's usually considered clinical success for a lot of the studies that I'll be referring to. In terms of diagnostic testing, this is a representative picture of what you would see in the lower esophageal, at the lower esophagus, really. And what you see here, or what they're trying to capture here, is that there's a tight lower esophageal sphincter. And for those of you who don't do endoscopy, you may not get a sense, but I think for those of us that do endoscopy routinely, you get a sense that this area is dilated. Now, on the barium esophagram, you can see here that this is the dilated esophagus and what they call the classic bird beaking for achalasia. And this is a tightened lower esophageal sphincter here. Now, of interest, you can also order, and I didn't get to this, go to this earlier, but for achalasia, you can actually order timed barium esophagams. And this is what the second picture is. And timed barium esophagams basically measure the barium content in the esophagus at 1 minute and then at 5 minutes. And so at 5 minutes here, you can still see that, and you can measure the column of barium. And basically, here there's still a large quantity of barium in the esophagus, which suggests, again, that there is a functional component to this of stasis. Now, I kind of harped a little bit on high-resolution manometry, but it becomes distinctly important because as we've evolved in our diagnostic testing, we figured out that achalasia actually has 3 main subtypes. There's type 1, which is categorized by just persistently high LES pressures. You can see here they're over 15 millimeters of mercury, and it's chronically high. And there's very little kind of pressurization or bolus pressurization here. In type 2, more than 20% of the swallows need to show this pan pressurization. So the moment this patient swallows, the whole esophagus is basically feeling a pressure sensation. And again, the LES is still high, the pressures are high here. And then type 3 is the spastic component, where basically you see these high pressures and you see this persistent elevation in lower esophageal sphincter pressures. It's important because in actuality, the responsiveness to therapy is best for type 2 and type 1. Type 2 responds the best. Type 3 is the hardest to treat. So in terms of management, there's pharmacologic therapy, endoscopic therapy. Botox has been you may have heard about in the past, pneumatic dilation, which I think Dr. Lambiase has done quite a few of. Per-oral endoscopic myotomy, which I'm going to touch on. That's the new kid on the block and has been around for probably about 5 years in this country. Surgical myotomy, and then esophagectomy for late-stage cases. I'm just going to briefly touch upon a lot of these and spend a little bit more time on per-oral endoscopic myotomy. So pharmacological therapy, it's the least effective. The most common drugs are calcium channel blockers and long-acting nitrates. There's sublingual nifedipine, which has been studied, as well as sublingual isosorbide dinitrate. The LAS pressure, typically you have to take these before a meal, varying between 15 and 30 minutes before a meal, and it usually lasts about 1 to 2 hours. And the LAS reduction is transient, but it's been touted to have a 13 to 49% LAS pressure reduction with nifedipine, and a little bit lower with isosorbide dinitrate. And the symptom improvement is about equivocal. But again, it's transient. It's associated with side effects, which usually negate its use in clinical practice for prolonged durations. The next thing is endoscopic therapy, and that's where basically we go down with an endoscope and we inject Botox at the LES in 100 units of Botox in 4 quadrants. And basically you prevent acetylcholine release, and it causes short-term paralysis of LES and results in approximately 50% reduction in basal LES pressure. And the initial response is high for about the first month, but then it starts to wane, and we see this in practice all the time. My experience is actually it's much worse than this, but at 6 months, usually I see a response maybe about 15-20%, if that, at about 6 months. But they were quoting here a 12-month response rate of 35 to 41%. The important thing to note is there have been studies that shows that it does complicate more definitive therapy, like surgical myotomy. Pneumatic dilation, which in the last 5 years probably has fallen out of favor, but it's worth mentioning. It involves a different kind of dilating balloon. We use 2 different dilating balloons. This is what they call a Rigiflex balloon. And this balloon dilates at 3, 3.5, and 4. And it's a forceful dilation of the LES. You do under fluoroscopy. You put it across the LES, and you insufflate. And the goal is to really fracture the musculus propria and the circular fibers of the esophagus. The average follow-up of 1.6 years showed a pretty good response of 74 to 90%. The problem, however, is the perforation rate. The median perforation rate, and this was quoted as inexperienced hands, was approximately 2%, which is fairly high. And then there's also GERD and GERD-related complications, which may occur after pneumatic dilatation in approximately 15 to 35% of patients. I'm going to jump to surgical myotomy, and I'll come back to per-oral endoscopic myotomy. So surgical myotomy really began in 1913. There were a few modifications since then, but it's basically cutting the muscle fibers, and they've modified it. The initial, in 1913, they were cutting dually. They were cutting anterior and posterior muscle fibers. They then focused on cutting the anterior muscles. But now, because of the reflux disease, they've actually had to add a fundoplication, and that's recommended by surgical guidelines. The effectiveness and its associated with reflux are here in this table. These are the large studies down here, but you can see that there's actually, throughout the surgical literature, they've actually had 4 different ways of doing the myotomy: transthoracic, transabdominal, transthoracic, and laparoscopic. The one that's been most studied is the laparoscopic myotomy, but the symptom improvement has averaged between 78% to 89%. On average, it's been about 84%, and the frequency of GERD is about a third of patients. And with the fundoplication, they get a reduction of about 8% to 14% with the fundoplication. Now, this is the symptom remission after a greater follow-up. with a laparoscopic myotomy. And here you can see down at the low of the table, about 84% have remission, and that's at 42 months. And that's in total with all of the studies over 100 patients or more. Now, there is end-stage achalasia, and what you see here in the barium esophagram is this is when it's in its early form. You see the classic bird beaking, but over time, the esophagus actually becomes saccular and dilates, and you get what's called a sigmoid esophagus. And this actually is late-stage achalasia, and it's very, very hard to treat with surgical myotomy. And so for salvage, they talk about doing a complete esophagectomy, and you can do colonic or gastric interposition. There is a high mortality rate associated with this of approximately 5.4%. So in the Lancet in 2014, this was the proposed guidelines for management of achalasia. So low surgical risk, and then age, and then you can talk about pneumatic dilation versus laparoscopic myotomy. And then you can talk about referral for further dilation or esophagectomy, and then repeat myotomy. And then high surgical risk, they talk about pneumatic dilation, botulinum toxin, and then repeat treatment or medication. The next couple of slides, I'm basically going to attempt to persuade you to show you that basically the newer techniques were basically going to disrupt this whole algorithm. And I think it's an exciting technique, and I think it's worthwhile discussing. So back in 2010 in Japan, Inoue and others created this extrapolated studies from an animal model into humans, and it was in a study of 17 patients, and it was called per-oral endoscopic myotomy. And what they did was they basically directed an endoscope into the submucosal space, and they created a channel through the esophageal wall layer to the lower esophageal sphincter, and then the tunnel was sealed after cutting it. And so here's a depiction, maybe hard to see, but here endoscopically they make the tunnel. They actually go down through the muscle layer, they cut the muscle, they come back up, and then they seal it here. And so I'm going to show you a video and this is from the ASGE in 2014, Digestive Disease Week. And it was basically an introduction to the concept of submucosal endoscopy. Oh, sorry. Let me go back. I'm going to skip ahead. I hate to hear myself talk. So, 1 second here. And let me see if I can play it. So, so basically, as I mentioned, the idea is it's an extrapolation from natural orifice transesophageal surgery, and basically you're separating the esophageal layers, and then basically it's a methodology that's evolved to get to submucosal targets, and it's been utilized most extensively in endoscopic myotomy. And here's the physiologic concept. Basically, you have a intraluminal space that's the mucosa, extraluminal space that's beyond the muscularis propria. And you have an unsterile compartment, which is intraluminal, and a sterile compartment, which is extraluminal. And you have a submucosal space, which you're going to use as a platform to get to the muscularis propria. And so, and at the end of the submucosal endoscopy, basically, you reconstitute the barrier and you create an unsterile and a sterile space. And you can do whatever manipulation you need to do for the target. Oh, sorry. I keep going back. Yeah, let me see if I can get to it here. All right. So this is the first step, which is creating that submucosal bleb within the esophageal lumen. And this is actually the way you get into the submucosa. And this is the actual tunnel within the esophageal wall. And so basically, the top layer is the mucosal space, and the bottom is submucosa. And this is actually the myotomy. So you're actually cutting the esophageal muscle in real time. And this is just a depiction of how you cut the muscle and what the attempt is in per-oral endoscopic myotomy. And this is a clip closure of the final tunnel. And you've reconstituted the barrier here, and you've crept an unsterile space in the lumen and a sterile space on the outside. And this is, again, just better pictures of the same process, but here they're channeling into the tunnel. Here's the tunnel creation, and here they're cutting the circular muscle fiber. And one of the things I like to point out with the esophageal myotomy, or the endoscopic myotomy, they're actually just cutting the circular muscle fibers and not the longitudinal muscle fibers that constitute the entire muscularis propria. These are called palisading vessels. This is in the GE junction, as you can imagine. There are some risks with this procedure. We always like to prove that we crossed the GE junction, because what we do is we cut 6 centimeters above the GE junction, then 2 centimeters below the GE junction. And the way we depict that is to show that the stained, that we basically stain the mucosa on the gastric cardia with kind of methylene blue. So is this effective? Well, I think a lot of the studies would show that. So this is a compilation of studies in an endoscopic myotomy white paper from 2010 to 2013. This was the original study with 17 patients. And as you can see, as you go through it, you can see that they had an Eckert score that was predominantly greater than 6 in almost all these studies. And they had a lower esophageal pressure. And they show before and after myotomy, and you can see that there was a decrease in pressure objectively in all these patients. The efficacy here, in monitoring the patients with a post Eckert score, was roughly 82% to 100%. And the follow-up was variable, but it was roughly up to 16 months. There are some adverse events, but they're actually quite rare, and they're rarer than pneumatic dilation. There's anesthesia risks, capnothorax, because we use carbon dioxide for all our insufflation, capnoperitoneum, mucosal perforation, full thickness incision, which are less than 10%, less than 1%, and bleeding is a small risk, and mediastinitis and leak is a rare risk, really less than 1.1%. There is, however, as they saw with surgical myotomy, an association with the reflux disease, and it seems as though it's almost on the order of surgical myotomy. Roughly a third of the patients get reflux disease. And in terms of the Poem versus Heller myotomy, there's a couple of slides. Nothing has been done head to head, but essentially we're looking at equivocal results here. Basically, the preoperative Eckert score was equal. The postoperative Eckert score was actually favored Poem, but the LES pressures were equivocal. Again, still favoring Poem, but there could be some publication bias here. And then GERD was actually a little bit more prominent with the esophageal myotomy, and PPI use was non-significant, but still higher with per-oral endoscopic myotomy. Another kind of data set in Portland showed very, very similar results as well. Again, a lot of this data suggests that Poem would be equivocal, if not marginally better than surgical therapy. Now it actually has been, POEM has actually kind of broken out of the mainstream. In a prospective registry from 13 centers in 2012 to 2017, published this year, they've actually shown that it's been effective in patients who have failed Heller myotomy. So a total of 51 patients with a technical success in 100%. So prior surgery does not impact our ability to do endoscopic myotomy. And basically 94% had clinical success. There were 7 patients that had adverse events, but none of them were devastating or life-threatening. So for persistent symptoms after Heller myotomy, POEM is a safe salvation technique. At least that was a conclusion drawn in this one study. So my feeling, kind of going back to the algorithm, I do think that there's a role for pearl endoscopic myotomy, and I think it's going to revolutionize how we approach these patients in the future. I do think that POEM would be a bridge to perhaps Heller myotomy or salvation thereafter. And just to let you know, POEM has also been shown, more recently, has been shown to be extended to other spastic disorders of the esophagus. Here you have, this is based on clinical success and clinical improvement in patients based on the Eckert score. And what you see here is even for jackhammer esophagus, spastic achalasia, diffuse esophageal spasm, a POEM, although these are small numbers, did show a clinical response, roughly 70 to 100%. Least of which it was for jackhammer, but there could be a role for a POEM in even these disorders. So just to go back to the case presentation, so this patient was actually a patient of mine who ended up having achalasia, but when I saw him in clinic, neuromuscular disorders of the esophagus, esophageal stricture and infection, cardiorespiratory etiology, and this should always be in your thought process. Okay, he's a 45-year-old male with some mild risk factors. Achalasia is not going to kill him immediately, but certainly cardiac disease certainly could. So we'd be diagnostic workup. Well, I would do a cardiac workup and then an EGD, barium swallow, esophageal manometry, which led me to diagnosis of achalasia. And in fact, these are all the management options I discussed with him. And in fact, he was my first POEM patient here. We did it about a year and a half ago, and he's done incredibly well, no symptoms, and his Eckert score is now 0. So we've done a series of about 5 patients here, one of which I think had come to Emory, and I had the privilege of meeting him there. And they've all had, 4 out of the 5 have had good success. One of the 5 was actually a revision from a Heller myotomy, and she had partial success. But I haven't seen her back in clinic. So just wanted to thank the GI staff and the GI lab and Plaza, which makes this all possible, my colleagues in the GI division at Erlanger, my family and mentors.
Thanks a lot, George. I had one comment and one question just for the residents. Anybody who's over 50 and has dysphagia to solids, sort of the first thing that you think about is cancer, and so EGD is the right way to go. As a matter of fact, there's some quality metrics out there that if you got a barium swallow in that patient, you'd actually get a negative check on that. But for neuromuscular disorders, barium swallow can be very, very effective. The second question, the question that I had was, is people with non-cardiac chest pain, and how often do you find an esophageal motility disorder, and what typically do you find?
So I think the literature kind of touts approximately about a 20 to 30% diagnostic capability with manometry. Usually it'll be a spastic disorder of the esophagus if you were to find it. The most common is actually nutcracker. Which the terminology has kind of fallen out of favor with high-resolution manometry, but nutcracker esophagus really has been the one that's been more common. Following that is probably diffuse esophageal spasm. I do it. Yeah. Yeah. So.
So, George, you mentioned, thank you for a great talk. You mentioned 30% of people may end up developing chronic GERD afterwards. Now, in the surgical approach, they have the option of doing a fundoplication at the same time as the one-step procedure. Now, for people who end up getting forms, now, is there like a salvage procedure afterwards that can be done? And how do you see the TIF evolving?
Yeah. So both good questions. So let me start with the surgical literature. So I didn't tell you what happens with these patients after they get a fundoplication. So approximately 50% of these patients still go on to requiring PPI therapy. So up front, if you look at, I have to look at the data, but if you look at cost effectiveness, I think up front, you're adding the cost of a fundoplication with not a gross change in reflux symptoms, and POEM you're getting almost the same response with GERD. So I'm biased, obviously, but I think that POEM would be, I think, equivocal in that scenario. I do see a role in TIF. Part of the problem is, like I told you, you're doing a fundoplication. There are different versions of fundoplication, but again, you're contributing to a motility disorder. So you can worsen peristalsis, worsen motility in that setting. And so I think the TIF, the transoral incisionless fundoplication is what he's talking about, would I think have some benefit. Because the way they do it, you wouldn't really be wrapping the esophagus, and you wouldn't necessarily be increasing the lower esophageal sphincter pressures. And I think the other thing to keep in mind in that scenario is that, what we talk about as the barrier between the esophagus and the stomach is really a complex set of multiple systems coming together. And you have the crural fibers, you have the diaphragm, you have the lower esophageal sphincter, and usually, whenever we disrupt that area, I think that it kind of leads to more complications. And so I think the TIF procedure really doesn't really complicate that anatomy all too much. So.
There's an overlap between people that have diffuse esophageal spasm and, of course, this motility and heart problems. 25% overlap, whatever. If you do a stress test, do you know why there is an overlap?
No, I think that's a good question. I haven't looked into that. But and that's why one of the things is, we have this resource here, and, with esophageal manometry, it's worthwhile doing a lot of these studies. In general, esophageal motility disorders are really understudied, and its associations with other diseases. I would venture to guess there's associations with pulmonary diseases as well, that really have not been well established.
In terms of ordering manometry here, is that something that is done outside of the gastrointestinal field, or is the interpretation going to be difficult to
Yeah.
primary care provider or kind of
Yeah.
screen more patients?
Yeah.
Something that we can order you guys to give an awesome report with a differential diagnosis,
Yeah.
or something that we should leave
Yeah.
to the gastroenterologist?
Well, I think that's a great question. And like I said, I have my own biases, but I think it should be a resource that's available, and but I'll leave that up to my division chief and my chair of medicine to answer.
I think we do quite a bit of open access manometry for metabolic patients who are getting gastric bypass. But usually I think I would favor that these things be sent to the GI office for a full evaluation, because manometry is a test, but these patients may actually require more detailed GI evaluations for if it's GERD, if it's a dysmotility disorder, or if it's truly somebody who requires an endoscopy. So I think bottom line would be that these people do that service and come to the GI office.
As a consultant, it's always a little frustrating to explain a test that somebody else ordered, because it's like, well,
Yeah.
I'm personally okay with somebody ordering the test as long as they can interpret it, think it through. But otherwise, if you think that you may need my help to sort through it, then I'd like to see the patient on time. That's just.
I think what they're speaking to is, I think one of the issues that comes up is, let's say you have a positive manometry finding, they still require an upper endoscopy to rule out, like let's say it's achalasia, required upper endoscopy to rule out pseudoachalasia and all these other things. And then, so it sort of becomes, I think that there's some benefits to it. I think you capture the diagnoses early, maybe, or capture more, substantial disease processes. But then I think it becomes challenging as a consultant to then go back and then have to figure out the endoscopy and who's going to schedule that. And so I think logistically it becomes hard.
And most of the manometries are sort of nonspecific. Achalasia, these findings are about 1 to 3. Most of the time you'll see something with this nonspecific esophageal motility disorder, which may or may not be a manifestation of GERD. So, you read out nonspecific esophageal motility disorder, eradicate GERD if present, but then you'll get a call back saying, well, they're on proton pump inhibitor, what do you want us to do? And I said, I don't know. I didn't see the patient. So that's sort of the dynamic with that. Okay, thank you.
Oh, no. Oh, no. Okay.
Yeah,
Hopefully I didn't give you a headache.
No, that was fine. I don't know what
I
happened.
have to rush you to the ER.
I bled on my